Wait a minute, it's Poland. Oh. Hi, Gerald Samson here. And I wanted to talk to you for just a few minutes about the upcoming meeting that we're going to have, sponsored by Orto-Fan Kursy. This is coming up May 10th and 11th. That's Friday and Saturday of this year, 2013, in Warsaw. This year's presentation is going to feature biomechanics, diagnosis, prognosis, and clinical applications for extraction, non-extraction, and the challenging borderline extraction situations. In addition, I'm going to cover in detail congenitally missing teeth, missing lower one incisor. How about missing two lower incisors, missing upper laterals, and missing second bicuspids. These will be covered in massive detail, including biomechanics, diagnosis, prognosis, treatment planning, and my favorite, troubleshooting. Let's take a look at a few examples of cases that I'm going to concentrate on. These won't be all of the cases, of course. These will just be a few examples. Let's take a look. Let's take a look at the information that I'm going to present May 10th and 11th, 2013 in Warsaw, sponsored by Orto-Fan Kursy. The theme of the meeting is going to be controlling the crowd, having to do with treatment planning, mechanics, diagnosis, and prognosis of crowded situations. Featured will be clinical applications, which will center on extraction, non-extraction, and the challenging borderline extraction situation. As much as possible, we would like to follow evidence-based information. This is our standard of care, of course. But in addition to that, we will want to be certain that you understand the effective techniques which I'm going to present. These will be fast and effective mechanics using things that you already have available in your practice. It would be unusual for you to have to purchase anything new. For example, fast and effective techniques. Let's take a look, and if you'll watch the cursor on the screen, let's take a look at this crowded situation here. We have a lower left lateral right up against a lower left first deciduous molar. Absolutely no room for the canine, and you can see the canine is present on the opposite side. In 3 months, I'll be showing you how to open that space for the canine with exceptionally simple mechanics. One of the more remarkable treatment responses of this type of technique using things you already have available in your practice is that the lower incisors only move forward approximately 1 millimeter. Imagine that. All of that space opening, that's 7 millimeters, maybe a bit more. The E space is still available, and the lower incisors have only moved forward 1 millimeter. Rather mysterious. I'll be explaining that in detail. Here's the same patient, space open, and now it's a matter of placing a lower lingual arch retainer and waiting for the permanent tooth to come in, the rest of the permanent teeth to come in, and then considering detailing and finishing. What treatment options would you look at for this particular patient? Perhaps taking out the lower right canine and hoping that the centrals and laterals will shift to the right. Admittedly, this is a technique I think many of us have tried, and it just doesn't work out very well at all. That is not what I have done here, and this is the same patient once the permanent teeth have emerged. Clearly now a non-extraction situation. Many clinicians would have considered taking out a lower incisor, perhaps the lower left lateral, in order to make space. That would have not been in this patient's best interest. But of course, we have to pay attention to how stable is the end result. This is the same patient 9 years after appliance removal. This patient is not wearing any fixed lingual retention. She is wearing some removable retainers, just a few nights a week, if that. You'll notice here that there is no frenectomy, no graft at the lower incisor, and the case is quite stable 9 years later. A very acceptable end result. However, one would wonder what her facial balance looks like. This is the same patient 9 years post-treatment. 9 years post-treatment. Very nice looking facial balance, done non-extraction, no frenectomy, no graft. From a frontal and profile view, quite acceptable. How do you think that was done? Let's take another look at a patient, a different patient, an 8-year-old. This particular patient has nice facial balance. And when we take a look inside of her mouth, there are some difficulties we encounter. Quickly count the teeth, and you will notice a substantial amount of crowding. There is basically very little room for the lower permanent cuspids. As you can see here, significant crowding and very rotated upper laterals. As well, the root morphology of the centrals appears to be fragile and tapered. Cephalometrically, this patient presents with a preferable lean towards non-extraction. However, that amount of crowding would present one with a challenge. How would you treat this patient? What would be the specific treatment sequence that you would follow? What I'll be showing are very, very specific sequences in detail using rather simplified mechanics. This is the same patient finished. The phase 2 treatment time was 13 months. 13 months done non-extraction. There was a first phase of treatment in order to gain adequate space to treat her non-extraction in this very challenging situation. And I'll be explaining efficiently the treatment mechanics and cephalometrics that went along with this case. As you know, a cephalometric course is being offered for a very limited number of people on Thursday before the main course starts on extraction and non-extraction. Let's take a look at this patient. Time 1, beginning. Time 2, updated records, ready for detailing and finishing. And you'll notice on your right screen, time 3, the patient looks very similar to time 2. That is because the second phase treatment only took 13 months. 13 months. The first phase treatment was rather simple and abbreviated. But perhaps the patient won't be showing a stable end result. Here she is 7 years post-treatment. 7 years post-treatment. Nice facial balance from a profile relaxed and profile smiling view. Treated non-extraction, and she also is not wearing any fixed lingual retainers. She is wearing removable retainers a few nights a week. Notice she has rather large lateral incisors on the upper arch. No graft at the lower anteriors, no frenectomy. In this crowding area, another patient that you'll be looking at is this particular patient who's about 9.5 years of age. Rather attractive looking girl. Attractive from a frontal relaxed as well as a profile view. But again, significant crowding this time on the upper and lower arch with a low attached frenum on the maxillary arch. And take a look here, a very fragile cortical plate. Very fragile cortical plate. Rather thin. How would you be thinking about treating this patient? Do you think this is an extraction or non-extraction situation? Are you certain you could do this non-extraction? And is it worth a try? Cephalometrically, she has a few other things, as did the previous patient, that would make me want to at least attempt non-extraction. What specific options and treatment sequence can you offer this patient? How aggressive will you be with expansion? Here is the same patient finished. No graft at the lower anteriors and no frenectomy. The treatment time in this case was 18 months for detailing and finishing. Here she is 1.5 years post-treatment, quite a pleasant looking young woman, and a successful non-extraction situation for a case that could have been treated easily with extractions, but perhaps not as desirable an end result. 1.5 years post-treatment. Was the non-extraction approach worth the effort? Take a look at the pre-treatment model and the post-treatment, and you make the decision. You've already seen her facial balance. If the effort was worth it for the achieved end result. How do you think that patient was treated? How would you have treated the patient? And I'll be showing that in tremendous detail. One of the other things that we will be looking at is severe ectopic eruption. For example, this lower right lateral is severely ectopic. Think about the mechanics that would be a good idea versus a bad idea. Think about where the root apex, if you'll look at the cursor, is compared to the canine. And as if I'm going to try to move the crown towards the midline, how will I avoid the root making contact? If I'm going to move the crown this way, how will I avoid the root tip making contact with the canine? What specific simplified, very simplified mechanics will be used? The mechanics, objectives, and treatment designs will be explained in detail. Here is the same patient. You might want to take a look and note that there is absolutely no root damage in this area. Here is her finished end result, done very efficiently. Again, no damage to the adjacent roots, no damage to the crown. Very straightforward treatment mechanics. Here is her facial balance. A case that might have been treated with a lower incisor extraction for the reasons which I will explain at our meeting in May. A better approach would have been to attempt non-extraction and see if the treatment result could be achieved as you are seeing here. As you know, if you've come to any of my other presentations for Orto-Fan Kursy, I like to discuss troubleshooting when things aren't working exactly the way we would predict. What if those cases weren't responding to a non-extraction approach? Which cases would be better to treat extraction from the beginning? Well, let's take a look at this particular patient. He has nice facial balance and profile. However, in smiling profile, you'll note that his upper incisors are extremely retroclined and unattractive. Look at the balance of his upper incisors to his face, how retroclined they are. This patient presents, not surprisingly, with a Class 2 Division 2 asymmetry. A Class 2 Division 2 asymmetry. Perhaps this would be a patient where one would consider taking out upper bicuspids only. Is that in the best interest of the finished result? Notice that he is a very, very brachyfacial, low-angle patient with a mandibular plane angle of 7 degrees. 7 degrees. From a crowning standpoint, it would not be necessary to take out teeth, but how will we achieve Class 1, given that the right side is full Class 2 and the left side is end-on towards Class 2, again, a Class 2 asymmetry? What are the biggest areas of challenges that one would expect in this case? Certainly would be deep bite correction, torque of the upper incisors, and how could this case be treated in a reasonable period of time, very challenging case, yet be treated non-extraction. You be the judge if the effort is worth the post-treatment end result. Do you think that the same result would be achievable, for example, with upper bicuspids out only? Very strong face, exceptionally flat mandibular plane angle, with a nice improvement in the angulation of his upper incisors, which would have been very, very difficult for me to achieve with extractions. In fact, there was a 25-degree torque increase of his upper incisors. How was that achieved? A 25-degree improvement in torque of the upper incisors. How would that have been achieved? One of the other things that I'll be covering in detail are congenitally missing teeth. Let's take a look at this patient. Obviously, the crowding on the upper arch is undesirable. Facial balance soft tissue is nice. Smiling, we can see his amount of crowding. And if we take a look, he is not just missing one lower incisor, he is missing two lower incisors. Congenitally missing two lower incisors. As you can see from the Panorex, you'll notice very quickly the lower centrals are obvious, and they are abutted by the canines. No space at all. Should I open up space for one incisor? Should I open up space for two incisors? Should I treat him non-extraction? Should I extract upper bicuspids only? Which of those options will give me the best possible end result? Perhaps I should take out two upper bis. How do you think that you would treat this particular case? What would you do? What do you think was done? Here he is post-retention. Do you think he was treated extraction or non-extraction of the upper arch? Do you think that I opened space for one lower incisor, two lower incisors, or did I not open any space for the lower incisors at all and treat him in a reasonable period of time with very nice smiling facial balance aesthetics? The specific bracket positions and archwire sequence will be discussed in detail with simplified mechanics and troubleshooting. Missing upper laterals will also be discussed. Here's a very, very brachyfacial patient with a interesting problem. Congenitally missing upper laterals, substantial diastema, tapered upper incisors, low frenum, and becomes more complicated when we see that this patient in fact has class 2 molars. What would you be thinking about for this patient? Finishing him class 2? Well, that'll be rather challenging. Treating him to class 1 and implants, is that best for him? Which implants are most likely to fail? What's the best age to place the implants? Which patients are not candidates for implants? We will be discussing this particular patient in detail, again with simplified mechanics and the archwire sequence that I would recommend. These certainly won't be all of the cases because I'll be showing extraction mechanics and extraction cases. I'll be showing the extraction mechanics and extraction cases in detail, as well as not extraction approaches for patients that should be approached in that particular way. May 10th and 11th in Warsaw. Don't even consider missing this particular course. I guarantee you will have a wonderful time have wonderful information and a very detailed manual for the course. Join me and my friends with Orto-Fan Kursy for an excellent experience.